Assalamu alaikum. This talk is about TCAR, transcarotid arterial revascularizations versus transfemoral carotid stenting versus carotid endarterectomy. As you know, TCAR has been evolving in the past 5 years or so dramatically that people hardly do any, well, I shouldn't say hardly, but the amount of open carotid surgeries that are being done in the United States on the downslope, and less and less people do open carotids now for a variety of reasons. It's an easy procedure to do. It has really good outcome, and it's one procedure that most people, even simple people with minimal endovascular skills, can do this procedure. Just a little bit about the guideline for basically screening for carotids or symptomatic, obviously evidence of carotid disease, bruit, an exam, and also the usual players: hypertension, hyperlipidemia, smoking history, family history. About 1/3 of the strokes in the United States, at least, they are caused by carotid embolization or ruptured atherosclerotic plaque. Carotid endarterectomy is basically has a long track record, 65 plus years. It's a technically feasible procedure. It's fun to do. It has low stroke rate. It has side effects such as nerve injury, etc., pain. In the CRIST trial, there is when you compare it to carotid stenting, there's almost twice as much MIs for carotid endarterectomy when you compare it to carotid stenting. And cranial nerve injuries are more common, obviously, in carotid endarterectomy. So it's low stroke rate, higher surgical morbidity, including MI, cranial nerve injury. When you talk about carotid stenting or transfemoral carotid stenting or carotid stenting in general, it has transfemoral carotid stenting has double the rates of perioperative or peri-procedure stroke rate. And again, the CRIST trial showed almost twice as much stroke with transfemoral carotid stenting when you compare it to carotid endarterectomy. I want to use this opportunity, maybe this is a little bit offline, to go over briefly, very briefly, about the major clinical trials that really talked about carotid stenting. CRIST is a very important trial. It's basically the takeaway message is basically carotid endarterectomy has more MI rates, and the carotid stenting has more stroke rates. But they concluded that basically carotid stenting can be used as an alternative to carotid endarterectomy in those cases where you cannot do carotid endarterectomy. Simply if you have a very high lesion or you have a radiated neck or redo. Although redo, for me personally, I do redo all the time, but there are some people intimidated. There's definitely more risks with nerve injury, etc. The next trial is the ICSS trial, International Carotid Stenting Trial, and the key finding, the stroke rate was higher in the stenting. Again, there's a higher stroke rate in the transfemoral stenting when you compare it to carotid endarterectomy. And the Sapphire trial, which is a trial, also an important trial, and a lot of cardiologists and neuroradiologists will code this procedure, this trial, basically for high-risk patients. And I have some slides later on to talk about Sapphire trial. But basically, for high-risk patients, they found that really there's not much difference in terms of carotid stenting and carotid endarterectomy. Carotid stenting is a valid alternative in high-risk patients. When you look at the ACAST-1 trial, also, this trial that was criticized as well, but looked into asymptomatic patients, and they found that carotid stenting is non-inferior to carotid endarterectomy, and preventing basically MI and death. SPACE trial, or stent protected angioplasty versus carotid endarterectomy, it's an old trial as well, showed no significant difference between the 30-day stroke rates, but carotid stenting had slightly higher rates. And the criticism from the interventional standpoint that the stents were used in this trial, the old stents, and for instance, now they're using double mesh stents, etc., and filters. The usage of filters. And there are two other trials that are ongoing. Rodestar trial, which is not ongoing, but there's a follow-up, basically, which discussed TCAR. We're going to go over in details, and then CREST-2 trial is still on. TCAR has been on the rise in the United States. I can tell you see the number for TCARs increasing over the years. This as far as for 221, but I can tell you, at least in the region where I practice, which is Los Angeles area, there's probably, at least I can safely say, close or more even than 50% of the cases are being done via TCAR. And the reason is TCAR is an easy procedure to do. You do not need advanced endovascular skills to do it. It's nothing like doing a transfemoral carotid stenting. I know somebody who's 76-year-old still practicing vascular surgeon who has very basic endovascular skills. He does TCAR and he has no problems doing them. So that's what TCAR did. It made people who otherwise could not do carotid stenting or transfemoral carotid stenting, it made those people able to do carotid stenting via carotid cut down or via TCAR, and it has a very good outcome. If you look at the 10-year outcome for carotid endarterectomy and carotid stenting, really it's the same in terms of recurrence, mortality, etc. But it's really the difference between the two is really the 30-day postoperative, first 30 days postoperatively, and where you have more stroke rates in the carotid stenting group, and you have more MIs in the surgery group. On the other hand, if you look at the outcome, basically with carotid stenting versus transfemoral carotid stenting versus carotid endarterectomy, in the Sapphire trial, it was favorable for stenting, and although it's not much difference in terms of the. If you look at the Sapphire trial, the stroke rate was at 1 year, and 3 years was comparable. In this study, death rate was higher in the carotid endarterectomy, and MI rate was higher as well. So this study was designed basically to evaluate those high-risk patients. The emerging role for transcarotid arterial revascularization, it really has a lot of compelling reasons, and it has a good outcome as well. So the TCAR has emerged as an alternative option for carotid revascularizations, period. Even in old days, when I was in training, we used to hook up the IJ, the internal jugular vein, with a like 7 French sheath or 9 French sheath, and hook it up with the common carotid during carotid endarterectomy and achieve reversal flow without a filter but that some people have been doing for a long time. And then what TCAR has basically has a filter here, and there's a reversal flow. So when you put it on, the flow wouldn't go to the brain. It will come through and drain basically through the filter and drain into the common femoral vein. And that has been instrumental in stroke prevention in this procedure. And also, as we will see in this study, if you clamp the carotid artery during surgery and you sew in a patch most of the time, it takes maybe 15, 20, 30 minutes sometimes. In this case of TCAR, it's about, depends how fast you are, but I would say probably on average 10 minutes. You can you use the reversal flow only for about 10 minutes or so, and we'll see that in this presentation later on. But the other reason why people like TCAR, because you avoid the arch. If you look at the ICSS trial, basically the investigator looked into those patients who have had silent hits in the brain, and silent hit meaning embolization in patients who are asymptomatic. Recently, there have been multiple talks, virtually in every meeting, especially for those who do thoracics, about brain attack and silent strokes and cognitive dysfunction, etc. But if you look at the numbers here, out of so about 50% of those patients who underwent carotid stenting had silent hit, and a lot of people who do carotids, in this country or elsewhere, they do transcranial Doppler, and you can tell live, when you have a hit or not, when you have embolization or not. Of the 50%, about 18% were actually embolization into the contralateral carotid. And that makes sense. If you're doing a right carotid, you have to go through probably the left carotid, and you have to go through the entire arch. And, even a manipulation of the arch with a pigtail, technically you have a small risk of stroke. A silent stroke, some literature reviews talks about 3%, of the patient can actually get silent strokes with just putting a pigtail in the arch. Whereas when you look at the carotid endarterectomy, only 3% had contralateral, and 18% basically had embolization. So the amount of hits with the carotid stenting is about 3 times more than carotid endarterectomy. And half of those were like on the ipsilateral, non-ipsilateral side, on the contralateral side. When you look at the capture registry, 18% of the strokes basically in those patients were non-ipsilateral. That's disaster, When you look at the Sapphire trial, 33% of the stroke were actually non-ipsilateral as well. So it's a serious issue. The PROOF study looked into DW MRIs and looked into TCAR. Basically, what they found is basically TCAR has similar when you look at the CREST trial overview, and we talked about it, I'm just going to be brief. It really just talks about stroke rates almost double for carotid stenting, MI rates almost double for basically carotid endarterectomy. Cranial nerve injuries, a lot more, about 4.7% in carotid endarterectomy, and very little in carotid stenting. And just a little bit more elaboration about the proximal protection and reversal flow. You make a cut down at the base of the neck, above the clavicle, about 1 cm or so. You dissect the carotid, and I place personally vessel loop. Some people place umbilical tape, some people clamp. If you clamp, though, you have to be aware of the recurrent laryngeal nerve. Sometimes it crosses underneath, and you have to be very careful. I personally dissect underneath, make sure that there's no nerve, and place my vessel loop before I do anything, just to avoid injury. I've seen at least one recurrent laryngeal nerve injury with TCAR. If you're on the left side, you always have to be aware that there's a thoracic duct also there, so you have to be careful. Everything like in vascular surgery, you have to be super careful when you dissect with anything, essentially. So you place a 9 French sheath, and then you heparinize, you have adequate ACT. Before you do the angiogram, before you start working, you turn on the reversal flow system. And the flow goes down from the carotid through the filter, through the common femoral vein, and then you start working. And that working process, most people will probably place a stent and be done in about 10 minutes once you have the reversal flow system. So in most cases, on average, let's say that you need to reverse the flow in the brain, and the brain will not have any flow from the ipsilateral carotid side, whatever side you're working on. It's about 10 minutes, so it's not bad. Let's talk about RODOSTAR study, which is the TCAR study, that prospective multicenter single-arm trial for high-risk surgical patients with carotid stenosis. So what they found in this trial, that stroke rate, when you enroll patients per protocol, is 0.7%. In the intention to treat analysis, it was 1.4%. And when you compare it from CRIST trial data, carotid endarterectomy rates, stroke rate was about 2.3%. So it's a little bit better. And when you talk about stroke and death combined, it was comparable to carotid endarterectomy. This has led people to use TCAR more, and enrollment in basically VQI system. And if you look at the MI rates were also comparable in this in the two modalities. RODOSTAR 2, again, stroke rate in the intention to treat, into the per protocol patients was 0.6%. And the intention to treat analysis was 1.9%. So this study also keep in mind, because patients, 81% of those patients, of the doctors, were new to TCAR. Again, not everybody in the past was able to do carotid stenting, because transfemoral carotid stenting, because it's technically demanding, and you have to have experience to do it. Whereas those physicians who did TCAR, the learner curve is very fast, very quick. It's an easy procedure to do. But so it was excellent outcome. It was very good outcome, and basically people are doing more. When you look at this JAMA study, the JAMA study from basically 2019, they looked into TCAR versus transfemoral carotid stenting in the VQI registry from 2016 to 2019. And basically what they found, they looked into in-hospital stroke, death, basically as a composite outcome and or endpoint. They looked into stroke, myocardial infarction, 30-day, 1 year ipsilateral stroke and death as well. And there are multiple physicians, over 1,000 physicians, 319 centers. It's a large study. They looked into even who are the specialists that they did the procedure. Look into whether vascular surgeon, neurosurgeon, cardiologist, etc. And the same thing, they looked into carotid stenting, transfemoral carotid stenting. And they did a propensity match, and what they found is essentially here really is that stroke rate and death rate is twice as much with transfemoral carotid stenting when it's compared to TCAR. And that was very compelling, although it's not a randomized trial, but it's a large data. It has heterogeneity. It's a pretty well designed study. When again they looked at the VQI data also from 220, what they found is MI rate with TCAR is less than basically carotid endarterectomy, and we're talking about 6,000 patients again in this study. So cranial nerve injury also a lot less. Again, remember that the vagus is there also when you do TCAR. You have to be aware of the vagus, but the most common injury I've seen people get into is recurrent laryngeal nerve, and mainly is a clamp injury. Some people put the clamp horizontally like that, and then the nerve goes underneath the artery, they clamp it, and it gets injured, basically. So I have seen this at least once before. So this basically, when you look at the stroke and death rate between carotid endarterectomy and TCAR, it was comparable on at least a presentation that was done in 221 for the VAM, Society of Vascular Surgery. That, as you know, we are operating on more and more older patients every day. It's not uncommon now for us to operate and do bypass or carotid or something on an 85-year-old man, and even 90s in some cases, at least here in the United States. So this study looked at the impact of age on hospital outcome after TCAR versus transfemoral carotid stenting versus carotid endarterectomy. And you see, there are a large number of patients here that were actually studied. And what they found that in patients above the age of 80, TCAR was associated with 72% reduction in stroke rate and 65% reduction in stroke/death rate. That's a pretty significant. These findings basically really led us to conclude that probably the best modality for this group of patients is really TCAR, because the outcome is so good, and it's much better for sure. I would say even in some cases probably better than even open surgery. This is another study that looked into the same comparison, and the study is a very large study, 33,000 patients. 50% of those were symptomatic, because that's what patients come to the hospital for. The older patients, they have TIAs, they have minor strokes, they have major strokes, etc. The majority of procedures were done carotid endarterectomies, because up until 4 years ago, I'd say, people have done more and more open carotids, which now the shift is going into doing more and more TCARs. At least 1/5 of the patients were undergoing revascularization for asymptomatic or symptomatic carotid endarterectomy stenosis were octogenarians. These greater proportion of patients of TCAR were performed actually on, greater proportion of TCARs were performed on octogenarians. TCAR were more likely to happen in those patients who had multiple comorbidities. After adjustment, basically the TCAR has similar 30-day, 1-year rates, stroke rate compared to carotid endarterectomy, whereas transfemoral carotid stenting has higher complication rate. This is a prospective study on a smaller scale, where they looked into a single center experience, high volume, 501 patients, 347 open carotids, and 154 TCARs. There was no difference between both in terms of the symptomatic status. TCAR has had more patients with hypertension, coronary artery disease, and congestive heart failure. Conclusion: the study showed basically that using propensity matching for both TCAR and CEA have similar 30-day preoperative outcomes. If you look at the peri-procedural stroke in those patients, so in the Rodestar 1 and Rodestar 2, basically per protocol patients, it was 0.7% and 0.6%. When you compare it to CRIST trial, stroke rate was 4.1%. And if you look at the TCAR also across VQI, across every study that is done, TCAR has lower stroke rate or low stroke rate. And again, TCAR is one of those procedures that's not very complicated. It's easy to do. And people who you do not, as I mentioned before, you do not need to be savvy with endovascular skills to do TCAR. Anybody with basic skills probably can do it. If you look at the 7-year outcome for TCAR on the surveillance project for the Society of Vascular Surgery, what they found, when you adjust rates of stroke and death over time, they found that TCAR and carotid endarterectomy has pretty comparable risks. When you look at the transfemoral carotid stenting, there's clearly, across the board, higher risk of stroke. That's a pretty compelling evidence. When you, this is a very nice slide when you look at this diagram that looked into a stroke and death rate and compared carotid endarterectomy versus TCAR versus transfemoral carotid versus carotid endarterectomy versus transfemoral carotid. And what they found, carotid endarterectomy stroke rate, combined stroke rate with death is 1.3% versus 1.6%, TCAR 1.6% versus 2.9% for carotid stenting, and 1.3% for carotid endarterectomy versus 2.9% with transfemoral carotid stenting. And that's a pretty good indicator to tell you that probably carotid endarterectomy in good hands remain the standard of care. However, if you have somebody who does 1 or 2 carotids a year, they don't have as good as outcome as somebody who does 50 a year. So it's all relative, but average good surgeon that does number of carotids like 20, maybe 20, 30 a year shouldn't have more than 2% stroke rate. If they do, usually that's they shouldn't do it. When you look at the transfemoral carotid stenting, and we can't really eliminate it completely because they are a subgroup of patients. That's the only thing that they work for them. For instance, I usually used to do about 20-25% carotid stenting a year in my old days. Haven't done many since 220 or 221, 220 probably. But every year I do 1 or 2. And these patients typically they have either disease common carotid artery that you can't access. They have radiation in the base of the neck, or they have other reasons. They have previous surgery. They have something that basically too sick to be, and they need to be done under minimal sedations, and so forth. But so there's always a place to do transfemoral carotid stenting in subgroup of patients. But this should never be the first choice, in my opinion. Although in the United States now, the largest payer, Medicare, pays for transfemoral carotid stenting even for asymptomatic patients, because the data is there's a lot of data basically advocates for that. But the reality is, no matter what you look at, how you look at it, TCAR and open carotid endarterectomies have better outcome than transfemoral carotid stenting. Having said that, transfemoral carotid stenting becomes necessary in certain patients with certain pathologies. such as like most commonly probably diseased common carotid artery that you can access for TCAR. The lower stroke rate associated with TCAR and carotid endarterectomy, hence these procedures are preferred. When you compare basically in sick patients who have risk for MI, risk for comorbidities, CO2, because TCAR you can do under local as well. And you can do carotid endarterectomy under local, but not every institution is capable of doing cervical block and adequate and so forth. But one thing to keep in mind when you're doing these procedures, TCAR versus carotid endarterectomy, you look at the risk for the patients. If the patient is sick, probably would benefit probably more with TCAR if you don't have a good anesthesiologist that can do a cervical block. If the patient has a high lesion, C2 and above, and it's probably doing TCAR probably safer than just doing open. If you have a small internal carotid, probably open better than TCAR. So you have to look at each case separately, but you have to keep in mind that at least in recent data shows TCAR has a little bit less medical complication than TCAR, and less cranial nerve injuries. But in most literature, carotid endarterectomy is still at least equal or superior to TCAR. Again, there's another study looked into TCAR versus transfemoral carotid stenting in those patients who has hemodynamically significant carotid artery stenosis. And what they found is, if you look at this Kaplan-Meier stroke death rates at 1 year, it was higher in the transfemoral carotid stenting versus TCAR. So as we saw in this review, there are at least multiple reviews over and over showing TCAR is superior to transcarotid femoral stenting. This study compared patients who have contralateral carotid artery occlusion with in patients who underwent TCAR, carotid endarterectomy, transfemoral carotid. And the reason is because when you do TCAR, you have reversal flow. So as you see here, you have reversal flow. When you work, once you start working with TCAR, you do not have any blood flow going in the brain. And technically, you should be, or some people think that you could be at higher risk of stroke. When they compared carotid endarterectomy versus TCAR in those subgroup patients, they found that TCAR was associated with 50% reduction in risks of stroke, death, or myocardial infarction. When they compared it to transfemoral stenting, they found 70% reduction in death and 74% reduction in combined death and stroke, and 65% reduction in both, actually in combined stroke, death, and MI. The odd ratios were lower in the TCAR group compared to transfemoral stenting. When you compare carotid endarterectomy and TCAR seems to be better in those patients who have asymptomatic disease, and it turned out to be equivalent in those patients who have asymptomatic disease. In this study, they looked into redo surgery for restenosis. Essentially, we still once a while redo carotid endarterectomy. Especially those patients that you cannot put stent in them. I do typically probably maybe 2-3 a year redo now, open, and then there are certain ones that we do basically with stent or we do TCAR. Basically redo carotid endarterectomy cause reduction in stroke rate 54%, MI 68%, stroke and TIA 58%, stroke and death 52%, stroke and death and MI 59%. So again, transcarotid surgery associated with reversal flow, as you see here, the arrows. And when you compare it to transfemoral stenting, TCAR has been associated with reduction in stroke TIA in about 63%. So the TCAR was associated with significantly lower odds ratio in hospital stroke, MI, and death. And when you compare it to redo carotid endarterectomy, and lower odds ratios in stroke and transient ischemic attack when you compare it to those patients who had a transfemoral stenting. So, and that's what we do. When I have a patient who has restenosis, I do essentially try to do TCAR, but sometimes the patch is too big. Sometimes they are anatomically, they are tortuosity or whatever reason, calcium, whatever reason is. Sometimes we can't stent those patients. So I go only to redo surgery now if they're not candidate for TCAR and or transfemoral carotid stenting as well. TCAR also been associated with improved center level outcome. If the centers who do TCARs, they had about 10% reduction in their major adverse carotid outcome. Because TCAR has good outcome, it's a relatively easy procedure to do, and that's why people doing it. If you look at the procedure time, it's basically 76 minute average versus 170 minute. 170 minute, that's probably a little bit, at least in our institution, we do it a little bit faster. It's about an hour and a half to between 1 hour and an hour and a half, depends. But TCAR, definitely, it's about 40 minutes even. We do it about 40 to I'd say to 60 minutes to 70 minutes. In the flow reversal is about 10 minutes for TCAR, clamps about 31 minutes here in this study. And again, we talked about that earlier. You know, so once you're ready to go with TCAR, things go quickly. You do them most of the time. It's between 7 to 10 minutes. I think you should be done with the procedure. Like anything else in medicine, you talk about cost. Cost is important. And then experienced hands with low complication rate, carotid endarterectomy costs between $7.5 to $10,000 for 1 to 2 days. Usually we send these patients home the following day. A little bit more expensive with carotid stenting, and it's the most expensive procedure is TCAR. But the major payers and insurances pay for all three. They approve all three. It's whether to do this TCAR versus transfemoral versus carotid endarterectomy is solely depends on the physician's discretion and experience. The flip side of it, some people say TCAR takes less operative time, less anesthesia, less OR time usage, also less complication, less nerve injury, less disability, and that's all money. This remains to be seen. There's no doubt about it. It's more money to do TCAR than doing carotid endarterectomy. When you look at the surveillance project from 2020, when you look at the patients with, when you compare on the patient who have received TCAR versus open surgery, there is an 86% reduction rate for cranial nerve injury, 47% reduction rate of MI, 48 minutes shorter OR time, and only 12% of the patient basically stays in the hospital for more than 1 day. And that could be from MI, could be from hypotension. In this slide, I wanted to go briefly over the common carotid artery evaluation. In order for you to do TCAR safely, you have to have essentially disease-free common carotid, as you see on the ultrasound. A little bit of disease is okay as well. But if you have severe disease and calcium, these patients probably better for either open surgery, or if you cannot do open surgery, these the group of patients that we do transfemoral carotid stenting. With someone like that, see here, that's clearly not a candidate for TCAR. And patients who have severe calcium like that, these are not candidates for stenting either. So remember, even if the lesion is high and it's very severely calcified and so forth, you still can do surgery. You still can do, jaw subluxation. You still can do all these maneuvers, nasal intubation. A lot of times you can pull the carotid down once you dissect it. So there are things you can do, but you shouldn't really do TCAR on a patient like that, because that can cause a problem. Again, unfortunately, recently TCAR has been overused for patients who have circumferential stenting, or so stents aren't expanding. Patients getting TIAs. This patient had almost near occlusive lesion after they've done carotid stenting, so we end up taking the stent out, and maybe 1 in 2 years I have to take one stent out like that and convert it to just carotid endarterectomy with patch, just like that. And some patients, they're not candidate for carotid. I mean, they had a radical neck here, radiation, had previous surgery. So TCAR basically has really shifted the care for carotid disease. It's minimally invasive, avoids the arch, avoids cranial nerve injuries, high rate flow reversal rate, prevents stroke, accurate stenting, just because the pushability, and you're not trying to stent somebody from the groin. The stent, it's right there by the neck. It's talking about a few centimeters, just about 20 centimeters or so, 15 centimeters even in most cases. So it's very accurate. It's a very nice procedure. And this is I took this filter from one of our cases. So that filter, that basically you see it in the TCAR system, and you see how much debris getting into the. Not every case, obviously, but this was more dramatic. When we saw this, we were shocked with it a little bit, but that's what happens. That's why filter is good. So I don't want you to walk away from this, that TCAR should be done on everybody. It's nice to, if you're doing carotid surgery, I don't want you to walk away from this presentation and thinking that TCAR should be done on everybody. As a vascular surgeon, as a contemporary vascular surgeon, you should be able to do both. You should be able to do TCAR, you should be able to do carotid endarterectomy. And if you have experience, or you can do transfemoral carotid stenting, that would be plus, because then you can decide what's best for your patients. So if you have a patient with high lesion, big neck, circumferential calcification, radiated neck, previous surgery, etc., these patients are better off to have TCAR or transfemoral carotid stenting, especially with the previous surgeries, radical necks and radiation and so forth, or you have common carotid artery disease. In those patients with relatively low risk, low bifurcation, average bifurcation, thin patients, if you have good experience with open surgery, open is not a bad way to go. If you have patients has liquefaction or has thrombus and soft lesions, then these patients probably better to have open surgery. If you have a patient with circumferential calcification, these patients are better to have open surgery. So it's all about selection. And you should be able to see the patient, look at the CT scan, look at the patient comorbidities, look at the patient lesions, basically, and decide what's best for the patient. In addition, I haven't really talking about this during this presentation. There's certain, I don't know what the percentage exactly, but there are patients that we see they have recent strokes and they're not candidate for dual antiplatelet therapy, because as we will see in the next couple of slides, you have to be on the dual antiplatelet therapy or use Bernenta, basically use a antiplatelet therapy in order for you to do carotid stenting at least for 4 weeks. Their patients have side effects to these medications. Their patients elderly, they are at fall risk, etc. So if you cannot do dual antiplatelet therapy for 1 month, these patients shouldn't have TCAR. If somebody is getting a cabbage, also you're gonna put them on dual antiplatelet therapy, they're probably gonna stop them, and you shouldn't do TCAR for those patients. So still, again, you have to look at the patients and the indication, including antiplatelet therapy, etc., and decide what best fits for the patient. I wanted to use this opportunity and talk a little bit about medical therapy, high intensity statin therapy, atorvastatin, rosuvastatin, adjunctive medication for LDL-C. Basically, if the goal is not met, and the goal usually for LDL-C is reduction in 50% reduction from the baseline. Goal LDL in general for average risk patient is less than 70, and for high risk patients close to 50 or 55. You have contraindications to receive statin therapy. There are monoclonal antibodies on the market. Patients who underwent carotid endarterectomy, monotherapy is okay. Dual antiplatelet therapy, use short-term post-stenting. I use it for 6 months to a year, depends on the patient. A recommendation for TCAR is about 4 weeks, and 3 days before and 4 weeks after. Blood pressure control, 130/80. Diabetes or A1C should be less than 7. Lifestyle modification and diet, regular activity. Basically, that's very important medical management for carotid. So carotid disease is a medical disease as well, that you have to really be aggressive and treat it medically. In conclusion, TCAR, highest upfront cost, but best outcome for high-risk patients. Probably best outcome for high-risk patients. Carotid endarterectomy most effective for low-risk cases, comparable stroke rate and death and outcome with TCAR, but more a CNI or cranial nerve injury and MI. Transcarotid stent, transfemoral carotid stenting, it has higher risks. We talked about the cases that we can use that transfemoral carotid stenting, so it shouldn't be eliminated completely. There are cases that this is the only option to do. And again, you see the patient, you decide what's best for the patient, and you go from there. You shouldn't just have one procedure done in your hand. So you should be able to do at least TCAR and open carotid, and if you do transfemoral carotid stenting, that's a plus.